healthcare in the United States, I do think is defined by three challenges that we have. It is the complexity, it's the cost, and it's the health of the population.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm Jimmy Markham, Communications Manager for the Jindal School. In part one of Dr. Britt Berrett's interview with Den Bishop of Holmes Murphy, they had a fascinating and illuminating discussion about ways to get a handle on spiraling healthcare costs from the perspective of the healthcare insurance industry. If you haven't listened to that episode, I highly recommend that you do so now and then come back for part two, in which they focus their conversation on government-funded healthcare. Let's listen to part two now.
I want to pivot here if we can, because there's a lot of conversation in the country about Medicare and Medicaid and viability. And, Medicare has been since the 60s that marquee that represents, 30%, 35% of the market. And once you hit 65, that's your product, and supplemental will minimize some of the risk that's associated with the copays and deductibles. But tell us a little bit about your take on Medicare for All, what the rallying cry is, and what your thoughts are.
Sure. I think Bernie Sanders was brilliant.
Wait. This is a business broadcast. I gotta
go here.
Okay, you go. We might have to terminate the call, but you go.
Bernie Sanders was brilliant in figuring out how audiences would respond. When he would say single-payer health care, there's a small fragment of an audience that would cheer. When he said Medicare for all, which he meant the exact same thing, crowds would go crazy. The terminology is inclusive. It sounds so friendly. And the replacement of single-payer healthcare or government healthcare with Medicare for all, I think, is one of the things that has sparked that renewed interest in that type of health insurance delivery system. It's not healthcare delivery. Healthcare is delivered by hospitals and doctors and clinicians. It's health insurance delivery is what Medicare for all would be. And I think that move politically is what has really kicked that off.
Okay. So what's your take on that? Do you advocate?
I do not.
What?
That is they're shocking that would be the case. Here's the issue. When I look at the healthcare system, what my customers pay for healthcare looks very different than what Medicare pays for healthcare.
Absolutely.
And so our economic system of healthcare, which is very expensive, is built today on two different economic engines. One is a lower reimbursement level from government payers, and depending on geography and type of service, a much, much, much higher system from the private sector.
Right.
If those two things just blew apart in a nanosecond, and with a stroke of a pen, and every hospital and every doctor in America, all of a sudden, all they got was Medicare reimbursement levels, I don't believe that our healthcare system could react to that economic shock. I think there are things that we could do to stabilize Medicare. I think Medicare does an amazing job at many things. I think there's things that the private sector system could do without turning it upside down to fix the system. But I am not in favor. In fact, I gave a speech at a construction conference about 2 years ago, and the name of my speech was The Great American Healthcare Depression. So it was
wait, you're talking
my hope.
Yeah, where's your hope?
Here's my hope. Well, my point was I asked the room, I said, well, look back at the last 10 years in your construction industry. And these were large national construction companies. I said, how many of you was healthcare-related construction outside of, if you're not doing roads and bridges, but if you're doing buildings, how many of you is healthcare been your number one source of revenue in construction? Virtually every hand in the room went up.
Okay.
And I said, so wait, if we were to say Medicare for all, where's the money going to come from to do all this? And the room just went, oh no.
Yeah.
It is. So I think that this system that we have that has a lack of transparency, that's there, a lack of connection between all payers, I think we can deal with those kinds of things. And ultimately, I think that's where we will find a place where you get public policy and private policy and they'll come together. Again, hope. I'm optimistic there again. But I don't think we have to turn the entire system over to get positive reform. But I don't think that our efforts to date have really gotten to the root cause of some of our cost problems.
I think that's an interesting comment, the cost problems, because when you talk to individuals about the healthcare delivery system in the United States, superior. I mean, we have people traveling from all over the world to come here. And there's some conversation about international tourism. Okay, I get that. There might be I ran a hospital right on the U.S.-Mexican border, and there were some heart hospitals in that adjacent city that had comparative results with a tenth of the cost. Having said that, the bigger question I think we have is Medicare for all means you've got to function efficiently at whatever a Medicare reimbursement would be. And some would argue that we are so inefficient and use the word chaotic on the delivery of care that we confuse consumers and we duplicate and overwhelm and participate in unnecessary processes and systems. I'm all in on that. And I think if we could introduce smarter business practices, we'd see more efficiency. I think you would advocate that as well.
I would. Someday there's going to be a connection that's there. And it's a matter of what that connection looks like. And I think we can navigate that and navigate it well. If you go back to in my time of looking at this, the first real debate around national healthcare systems was under President Clinton. So if you look back at that, some learning from that.
Yeah.
That I actually pulled out some of those plans a year or two ago. And crazily enough, I wrote a book on healthcare reform, which I'm not sure why I did that, but it was an interesting endeavor. But I look back at that, and they had a Medicare for all single payer system was a concept. A public plan option was a concept that came out of that. But they had a third option, and it was called an all-payer plan. And what the all-payer legislation would have done would have been a Medicare reimbursement that would be the level of reimbursement that all payers paid. Was actually one of the ideas
Wow.
which would collapse this whole system. But from looking at that, I've really figured out what most Americans want. And it's not single payer. It's not necessarily Medicare for all. It's not all payer. I think what most Americans want is an other payer system. As long as somebody else will pay this, it would be awesome.
Yeah,
I just want somebody else to pay this bill. When you look at, and I don't think most Americans actually understand how much it really costs. And the gold standard in this insurance world is called the Milliman Medical Index. Yep. And Milliman's an actuarial firm. They work with insurance companies. They work with hospitals, and it's there. The average family of four in 2018, when you take what the employer pays, what they pay per paycheck, and then how much on average they pay in deductibles, coinsurance, copays, the actual expenditures. In 2018, that average cost is $28,166 per family.
A family of four.
Family of four, average in the United States is over $28,000. And most people, when they hear that number, think it's crazy. It can't possibly be that expensive, but that's actually what it costs to pay for the program, in the healthcare industry that we've created. So reform has to come in some fashion. It's just too expensive.
I agree, but 50% of the healthcare expenses are incurred by 5% of the population. So those numbers are meaningful when you layer in. There are some very sick individuals who utilize, let's say, use the word excessive amount of healthcare services. And until we wrap our brains around that, and deal with some of the ethical issues, the bioethical issues, $28,000 a year for a family of four, it's unbelievable.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
Well, let me ask you another question. Holmes Murphy has been very involved in gathering data, right? Mm-hmm. And analyzing and scrubbing the numbers. And how do you think that data will be used into the future? It appears that these millennials are willing to give up as much information as possible. They really don't care. They have no concern about sharing anything with anyone. But as you gather data, what are you going to be doing with this data? What do you think is going to be the primary role of data and information on the delivery of the healthcare system?
So number one, protecting its privacy.
Yeah,
I just finished our mandatory HIPAA training last weekend, and reminders that any of us who violate that may go to jail is a strong reminder that when you have identifiable healthcare information, you need to be very, very, very secure with that information. So we try to do as much as we can in an aggregated population basis. So as an insurance entity in what we're doing, it is very rare that we need individually identifiable patient information. And
you don't care. You can, if you can de-identify it, then you can start working with the numbers, which is kind of cool.
We don't want it because we don't want the risk of ever being a breach that's there. And I think most stakeholders in health insurance world kind of have that same mindset. The fear of a breach is so great that it's just better not to have it. But the aggregated information is so valuable to start to see how populations are moving. And you look at, I'll use an example. We had a customer here that they're a tool manufacturer that many of your audience would probably know that was there. And they decided a few years ago that they were going to take war on cancer as an employer. The CEO had some cancer in family history. They'd had large claims. Our chief medical officer looked through and said, hey, we believe that in your population there are 500 people who have cancer in their bodies today. Okay. Now, it may just be a few cells and just getting started, but it's there. Yeah. But it's there. They went through the process. They did education. That like everyone else, their cancer screenings were free, and they still weren't getting people to make a difference. They ended up finding out that the number one barrier to people getting their age-appropriate cancer screenings was not financial, because the plan covered it at 100%. It was time. They didn't want to waste a precious vacation day to go get a colonoscopy. And so what they started doing was offering a free paid vacation day if you got your age-appropriate cancer screening. Their cancer screening compliance rates went off the roofs, with the highest any customer we had ever seen, approached 90%. But the barrier to getting their screenings was simply they didn't want to take a paid time off day. And those are the kinds of things when employers start using data and seeing, wait a minute, we've got this group that's not getting this test, or patients who are struggling with diabetes are not getting their exams. If they start seeing that in the data, then they can make smart business decisions that actually can get people to a place of better health and better health care.
Did you help them navigate through that and get to that conclusion?
I would love to take credit.
Why
that
don't
was
you?
my
No one will
idea,
know.
but actually, it was not. It was not my idea. It was the team. Karen Rogers is a person on our staff who came up with the idea and was fantastic and a great result. And then the number of comments that start getting made. In fact, I got one inside of our company. In our company, you're going to get your age-appropriate cancer screenings. You're going to pay a lot more for health care. And I got a note last week from a woman in one of our offices that said in that mandatory screening, they found breast cancer at stage 1.
Wow.
And she's got her treatment plan. And she sent me a note and said, I thought this was a hassle, and why is the company making me do this? And she says, you know what? I think you may have saved my life. And I think that's what employers can do, but they have to have the data to be able to say, hey, we need to put an incentive, we need to remove a barrier, we need to figure out how people can get there. If they don't have the data, they can't get there.
And that's a role that Holmes Murphy is playing.
Yeah, it's not just Holmes Murphy. It's lots of stakeholders in that, but it's something that's important to us. We think that we can use the insurance platform to help save lives.
Interesting. Delighted to have you with us. I'm going to leave you for some closing thoughts as it relates to where do you think healthcare is going, but I'm grateful for the forward thinking. I love the idea of having hope, and that we do have an amazing healthcare delivery system that does more for more people than has ever been done in the history of mankind. But the confusing, chaotic nature of it needs simplification, and there's organizations like yours that are embracing that. So I'll leave you for some closing thoughts. Den, anything else you want to share with those that are listening in today?
Well, the 1 hour that I have to give my closing thoughts, I try to leave people with this, whether it's a customer or a prospect, someone we're interviewing, anybody I talk to, is that healthcare in the United States, I do think, is defined by 3 challenges that we have. It is the complexity, it's the cost, and it's the health of the population. If all stakeholders can align to remove complexity, make this easier, to get the cost under control so it is affordable, and to deal with the underlying risks that are driving the behaviors and choices that we as Americans make that are driving up our risks and creating disease. If we can reverse some of those risks, this system can work. And it is the greatest healthcare system in the world.
Well, we're delighted to have you. Dan Bishop is the president of Holmes Murphy, has decades of experience in the healthcare world, is helping us lead change in healthcare as we recognize that we are in the business of healthcare. This is Britt Berrett with the Jindal School of Management at the University of Texas at Dallas, and thank you for your time.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode notes, links, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu and then search under the Centers and Institutes tab on the navigation menu. Also, we want to hear from you. If you would like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z, and let us know how we're doing. I'm Jimmy Markham, Communications Manager for the Jindal School and the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.